Okay, welcome everyone to the Green Nurse Monthly Clinical Conversations webcast, where we bring hope and inspiration for growth and healing. Now in its 9th year, the Green Nurse podcast and Clinical Conversations is a core part of the Holistic Caring and the Green Nurse Network, which alongside of Bloom Hemp CBD completes our ecosystem. We have a saying around here: people are making great medicines, people are selling amazing cannabis formulations, yet no one is truly interpreting how to use cannabis as a medicine. And that's what we do. Cannabis nursing has been recognized as a specialty, and nurses are truly making an impact on advocating for the safe therapeutic use of cannabis and other plant medicines that support and nourish the endocannabinoid system for health, healing, and wellness. Welcome to today's webinar, Schedule 3 Reality Check. And I am honored to be your moderator for this critical clinical conversation. My name is Nurse Sherri Mack, and I'm the co-founder and Chief Nursing Officer of Holistic Caring and the Green Nurse and VP of Nursing for Bloom Hemp CBD. Today, we are joined by a distinguished panel of cannabis nurse entrepreneurs to discuss the recent Schedule 3 reclassification and what it means for healthcare professionals. Our focus is a reality check on how this shift impacts clinical practice, education, operations, and risk management. Each of our expert panelists will share their professional journey and offer invaluable insights on these vital themes. I will introduce them one by one, after which they will present their unique perspective on this slide deck that we have presented for you all today. Feel free to add your questions to the chat as we go. Our guest panelists will share their insights first, and then we'll open the door for a live Q&A at the very end. A recording of this presentation and a downloadable version of the slide deck will be made available to all registered guests. And as always, the presentation will be uploaded to our Green Nurse YouTube channel for you all to rewatch and share. So let's get started. Okay, so I'm just gonna set the stage now. So as cannabis nursing emerges as a distinct specialty, nurses find themselves at the forefront of patient care, where cannabis use intersects with clinical practice. And nurses are pivotal in managing disclosures, documentation, patient education, coordinating workflows, and making operational decisions. We are really, truly the game changers in all healthcare systems. Nurses often navigate cannabis in this complex landscape without the standardized infrastructure needed to fully support them and their patients. So to today's agenda for the webinar, we're going to discuss the clinical impact of Schedule 3. How will this affect nurses' daily tasks, such as documentation, reconciliation, and patient education? Navigating workflow challenges. What gaps are nurses currently facing due to lack of preparation and systemic support? Gaps in nursing education. What are nursing schools teaching and failing to teach about cannabis and patient care? Operational readiness for nurse leaders. What immediate steps can nurse leaders take to prepare their systems for these changes? And then the patient disclosure dialogue. How can healthcare professionals effectively inquire about a patient's cannabis regimen or consumption? How can healthcare professionals and nurses document their responses accurately and conduct these conversations in a manner that is free from bias and stigma? That's the big question. So we're going to start with the opening poll. I'm going to put the poll up right now. The first poll question, we're going to have a poll at the beginning and a poll at the end. And the first question is, if you're a patient and you're watching today, are you discussing cannabis use with your provider? And if you're a provider, are you asking your patients about their cannabis consumption methods? And the answer is yes, quite often, no, totally hidden, and sometimes it depends upon the patient. So I am going to give it a little bit more time, and then I will publish the results. I think we got 100%. There we go. Okay, so there we go. So basically it's about 50-50 yes and no, and sometimes depending upon the patient. Okay. So let's go to the next slide.
That is the truth.
That is the truth. Now I'm going to talk a little bit about drug schedules. Not going to get into a lot of detail, but kind of want to all let you know where cannabis has sit and where it's moving. So as you can see, this is the United States drug schedule, Schedule 1 to Schedule 5. Cannabis has been sitting in Schedule 1, highest risk for the longest period of time. And medical cannabis is going to be moving from Schedule 1 all the way to Schedule 3. Adult use cannabis is still on the table for a decision to be made later this month. They're going to have, they're having a hearing.
An administrative hearing beginning June 29th.
Yep. So anyways, so Schedule 3 is where ketamine sits, Tylenol with codeine, anabolic steroids, testosterone, and Marinol. And Marinol is synthetic THC that is available via prescription. So this is just for you all to have an awareness of what a drug schedule looks like, where cannabis was, and where it's moving to medically.
Yeah, and you can see the relativity with all of the other commonly prescribed drugs.
Yep. Okay, so rescheduling is a process, not an event. So this is taking time. This has been going on for years and years and years of rescheduling. You know, we've been advocates for descheduling for the longest time, but Schedule 3 shifts regulatory posture around medical cannabis in particular. It accepts the medicinal benefits. Research access is going to hopefully expand. Institutional barriers are hopefully going to become lower, and documentation expectations will increase with wider adoption. And this is intake forms, how we're doing our care plans, how we're teaching, how we're providing safety considerations for patients. Rescheduling does not create opportunity, preparation does. Okay, and again, this is just another powerful slide that is just really important. You know, I've been doing this work for the past 10 plus years, and cannabis has been sitting as a commodity. It's not a commodity, it's clinical. So currently it is seen as a commodity, as we see, you know, and when we look at what a commodity is the one size fits all approach that, you know, everyone's just smoking cannabis. It's value driven by price, mass produced by the market, you know, it's purchased based on preference or cost. When we're looking at it clinically, it's a little bit different, right? It's personalized to the patient. It's value driven by outcomes. It's formulated with science and consistency and recommended by a healthcare professional. So cannabis is a therapeutic option for so many patients, for so many different conditions. It's not just a product on a shelf. We need to treat it clinically and patients will benefit. So again, it's about patient care, not profit. It requires clinical expertise. It's not interchangeable. There's so many different types of products on the market that patients can use. They do not have to inhale in order to get the benefits, and it deserves the same standards as other medicines. And I think this would be really important for, you know, as we start to bring our speakers on, for us all to think about the definition of the therapeutic use of cannabis. So this has been defined in the scope and standards of cannabis nursing. It's also been defined in a lot of other books that have now been newly published. And the therapeutic use of cannabis is the use of cannabis products specifically for medicinal, wellness, and healing purposes. This includes adult use. It's personal and subjective to each consumer, with objective criteria being improvement in one of the 5 health domains. That's biological, mental, emotional, spiritual, and social, without negatively impacting any of the other domains. So it just kind of gives people a reference. You're either using it therapeutically or you're not. And this includes medical use and or recreational or adult use cannabis. So this is just something for the audience to think about. How many of you feel that you're using cannabis therapeutically after reading this definition? Okay. All right. And so now I'm get to the meat and potatoes, and I'm going to introduce our amazing guest speakers today. And we're really going to get into some juicy topics. Really, really excited. Again, my name is Sherri Mack. I've been the moderator. I've been a registered nurse for 38 years. Cannabis saved my life. And I have been on this journey of helping others to use this therapeutically for the past 10 plus years. I'm the Chief Nursing Officer of Holistic Caring and the Green Nurse in Bloom Hemp CBD. And again, you're all going to get a copy of these slides, and these little links here are live links that you can click on, and you can learn more about each of us and our background and learn about more how you can get in touch with us. So the first speaker that I'm going to introduce is Drudys Ledbetter. She's CEO and founder of Mack Consulting. Following Drew will be Meghan Zaklin. She's owner and chief of quality and safety at ECS Wellness. And then closing out this amazing speaking panel is Elisabeth Mack, who's co-founder and CEO of Holistic Caring and the Green Nurse and Bloom Hemp CBD. So now I'm going to pass the baton over to Drew. You are on, and let's get on with the show.
Absolutely. Good evening, everyone. I am so happy to be here with you guys tonight. My name is Drudys Ledbetter. I go by Drew. I go by Drudys. I'm a registered nurse with more than 20 years of healthcare leadership experience, spanning acute care, long-term care, healthcare technology, informatics, clinical operations, workflow design, and patient safety. I spent a lot of time identifying and fixing visibility issues in healthcare when we were interacting with technology, and we are now in a new era of healthcare. I'm a founder of Mack Consulting and also the founder of Project Destigmatize Healthcare, a nonprofit company that is focused on research to help improve and to help healthcare manage what it cannot see. Throughout my career, I've worked in environments where healthcare organizations were trying to improve outcomes and reduce risk and improve qualities and make better decisions. I've written 1,000 copies in my day. What I've learned is that one of the biggest challenges that we face is not necessarily a problem of effort or intention, especially when it comes to nursing operations. The biggest problems are really visibility. So tonight, I want to offer a different perspective on the Schedule 3 conversation as a clinician, as a clinical leader, because although Schedule 3 brings cannabis to the forefront, I believe visibility is the real story that we're facing, and cannabis is the perfect use case for it. That perspective comes from spending my career at the intersection of systems and workflows, so really understanding the barriers that exist. Next slide, please. So this slide is colorful because it just has the networks. One of the unique aspects of my work is that I'm allowed to move across multiple industries and professional communities. I've worked alongside nursing leaders, healthcare executives, technology companies, policy stakeholders, educators, researchers, and cannabis professionals as a cannabis entrepreneur. What I've noticed is that every group is asking a version of the same question. And the question really is, how do we make better decisions? And the answer really always starts with, we need better information. And better information starts with better visibility and better data capture. So whether we're discussing workforce challenges, patient safety, quality outcomes, social determinants of health, cannabis use, the underlying issues are often the same. We are having the same conversations. And I think that it's important for clinicians to really push themselves into every room that they have an opportunity to be in, because that is when we're going to hear the stories and we're going to hear the gaps that other industries are facing that we as nurses can actually fill because we are already in those spaces. Next slide, please. So what I believe is the most important point of this presentation is cannabis is not a problem. Patients are already consuming cannabis. They've been consuming cannabis for decades. The reality, that reality, like, it exists, right? It doesn't matter whether we rescheduled, descheduled, separated the plant or not. In Massachusetts in particular, what it creates is this divide that the plant is more than one thing, but the plant is this one thing, and it's a therapeutic thing, and it's a clinical thing. The real question really for me has become whether healthcare can see cannabis in its systems, whether healthcare organizations can identify it, can clinicians document it, can researchers study it? And that's really important. Can public health agencies measure it? Can nurse leaders understand its impact on workflows and safety and outcomes? So it's not really about whether cannabis exists or not. It exists. Visibility is truly the issue here. Next slide, please. And the more that we dig into this, I think that that's why Schedule 3 is often misunderstood. Schedule 3 did not create the issue. It really just exposed it. Long before any federal conversations about rescheduling, patients were already making decisions about cannabis. They were already self-managing symptoms. They were already combining therapies. They were already navigating healthcare systems that often did not communicate with one another. That exists today, and it's going to exist tomorrow. And Schedule 3 did not create the problem. It actually is just revealing the problem, because we have to start asking this new question. What happens when healthcare cannot see something that is already happening in healthcare? What is going to happen? And that's a big question. Next slide, please. In healthcare, we all know that if you can't see something, you can't measure it. And we also know that if you can't measure it, you can't learn from it. And if we can't learn from it, we cannot improve it. So I think that you see where I'm going with this, right? Because if we cannot improve it, we cannot build effective policy around it. And if we don't build good policy around it, we can't coordinate care consistently. It's a trickle-down effect. And that's why visibility matters. That's why it's important for cannabis information and data to exist in some form in our medical records, because invisible data creates invisible risk. And clinicians are not failing. Patients are not failing. The system is not designed to capture this information. And because the system is not designed to capture that information, a lot of issues emerge. That invisible data is going to create opportunities for nurses to fill these gaps in ways that we already know how. Next slide, please. So as we look closely, we can see exactly where those gaps begin to emerge. And my perspective is always operations. So when a patient walks in, we don't have an operational workflow to accommodate patients that have medical cannabis as part of their medical regimen. So cannabis doesn't show up in our assessments. It does not show up in our medication reconciliation. It doesn't show up in documentation. And when it does, it's often biased. There's a very well-known statistic that 30% of US Americans are consuming cannabis in some form, but cannabis only shows up in 0.4% of medical records. That means that they're doing it, but they're not talking about it. And if it doesn't show up in documentation, it can't show up in patient education. So we can't arm the consumers, the patients, with the information that they need. And it doesn't show up in care coordination. So we can't really coordinate care, ensure that patients have access. And in transitions of care, we can't see what medication interactions could potentially exist and what risk exists with co-exposure with cannabis and other medications. And we know that there's over 400 drug interactions. I'm trying to paint the picture for you, but I hope that you notice that these are not cannabis specific problems. They're operational problems. Cannabis is really putting it right in the forefront. And we now are facing that the operational gaps exist. And one of the most important examples of this cannabis visibility challenge begins with disclosure. Next slide, please. And I say this because as a founder of Project Destigmatize Healthcare, we launched the Patient Cannabis and Healthcare Experience Survey. And the data is talking. Patients are often telling someone, they tell family, they tell coworkers, they tell support groups, they tell someone that they're consuming cannabis. But they don't tell their healthcare providers because that stigma silences the data. Fear of losing life insurance, fear of losing veterans benefits, fear of losing their jobs if it's a workman's comp situation. There is judgment in healthcare. And again, we have years and thousands of research articles around stigma and how stigma shows up in healthcare and impacts health outcomes. And that stigma creates this loop that promotes a lack of trust between a patient and their provider. So when that disclosure disappears and we don't know what they're doing outside of the healthcare environment, that visibility that we typically have to make better clinical decisions, it goes out the window too. And when that visibility goes out of the window, the patient's risk increase, because if there is a co-exposure, if there is an opportunity to intervene with alternative therapies, we don't know. And that's why I often say stigma is not a social issue. Stigma is a patient safety issue, because stigma silences data. Next slide, please. And I just want to say one more thing, that if patient doesn't disclose, another important question emerges, right? So let's imagine a patient comes in and they say, I take cannabis. What happens next? Do we have a workflow? How do we intake this medication? Where do we store it? What is the policy around their use? Are they able to self-medicate? Do they need to share the dosage? How are we tracking what they're consuming when they're in our environment? Do we have a standard? Do we have a documentation process? Is there a follow-up process to make sure that they were able to access their prescriptions or their medications at home? In a city like Boston, where we only have 3 medical dispensaries left, patient access is a real issue. And clinicians are part of that care planning process. And we don't have a plan. Because if the answer is no to any of the questions, we haven't solved the visibility problem. We just like, okay, we've identified it. So this is when I say infrastructure becomes so essential. And cannabis is, I think it's special. It's not so special, but we need the infrastructure to really be able to operate in a way that is safe in healthcare environments. And as leaders, are being held accountable to patient experience and workforce safety. These issues are not one that we can continue to ignore, because every healthcare system requires a consistent response when new information enters the clinical environment. But we don't have one right now for cannabis. Next slide, please. So ultimately, this is about moving from that silence to safety. So we really want to move from stigma to data, because the goal is for us to be able to see cannabis as it exists in the healthcare environment. And that pathway begins with reducing the stigma, so that disclosure can increase. And when disclosure increases, then the data becomes available. And when the data becomes available, organizations can learn from that data. But they can only learn from that data if it's captured in a way that is usable. It's not about asking Epic to put in another free text data entry section in your electronic medical record. It's about asking them to allow that disclosure to trigger risk assessments with pharmacy, to trigger evaluations of co-exposure during med reconciliation, to trigger patient education, to trigger documentation in the care plan that is appropriate for that patient, so you can have documentation defensibility. When organizations can learn from the data that they capture, safety improves. This is why we collect data. This is why we measure data. And this is why nursing is data-driven, because better documentation and better data improves communication in healthcare systems. And that communication produces better research and better policy and better patient outcomes. And that visibility is really what makes all of that possible. Next slide, please. I think that what we're facing with Schedule 3 is a little bit bigger than cannabis, but cannabis is the perfect case study. What cannabis is revealing is broader challenges within healthcare. Healthcare often struggles to manage behaviors. They often struggle to manage exposures, and they often struggle to manage patient decisions that are occurring outside of the traditional clinical environments. The blind spots have always been there. Cannabis is just saying, hey, shine a light on it. We can see it now because it's very evident. The industry has been growing. We have added the medical benefit acceptance through the rescheduling of medical cannabis. But we continue to have a documentation challenge, a policy challenge, and patient safety challenge because we cannot see this data. And when it comes to operations, it really means thinking about what that patient experience is as they navigate through your environment. What happens at intake? What do you typically do when they come in with their scheduled medications? Do you send it home with their family and you order from the pharmacy? With cannabis, you won't be able to order from a traditional pharmacy. So do you have relationships with the medical treatment centers in your area? Do you know the product formulary? Do you have visibility to any of the information that you're going to need to actually produce a working operational plan to actually execute on the gaps that you identify in your organization? And I think when you return to work, it's really important to start thinking, or when you go in as a patient, it's really important to start thinking, what is going to happen? What is going to happen? What can I say? When you get your HCAP survey, when they ask you about your medications, if they didn't talk to you about cannabis, we have now federal coverage and rights to demand that cannabis be seen as medicine, which is good for patients, but it really puts nursing leadership in a hot seat because we don't have a plan on what to do when cannabis enters the room. Next slide, please. So my simple call to action is, I want you to think, I want you to have an opinion, and I want you to understand that this is not a comfortable time in nursing leadership and operational leadership. So it's really important that we begin to ask the uncomfortable questions that will lead us to better clarity and better visibility of what's happening in our own systems. Ask, how are we identifying cannabis? Are we asking the traditional question? Do you take illegal drugs? Yes or no? That causes so much confusion because a patient's medicine is not illegal, and federally, it's not illegal. So when you only have that as an option to capture cannabis consumption, you're already way behind. So thinking about how we're documenting it. Are we only documenting cannabis use disorder? Are we only documenting cannabis hyperemesis syndrome? How do we document the therapeutic use of cannabis in healthcare environments when we don't have an ICD code for it? So it's not simply us being on the forefront, but really asking legislation, asking the systems that are meant to support us, asking the regulatory systems, the Department of Public Health, public safety, to really get engaged and build the nuggets and the bricks that we need to create this infrastructure. Because cannabis is the issue that we're discussing today, and that's what emerging today is, but supplement use is up. I always joke around that everybody's on ashwagandha. So there's other things that are happening that we're going to need to be able to see. And cannabis is our perfect moment because it allows us to see, allows us to educate, and it allows us to honor the plant the way it was meant to be honored as medicine in our healthcare environments. The reason we need to build the infrastructure is so that we don't lose the plant as we're trying to integrate it into our healthcare systems. That is my last slide. I hope that this was new information, and I think you're passing it on to Meghan or Sherri.
Yep. Meghan Zaklin.
Thank you, Drew. That was incredible. Thank you for setting the stage. And thank you for everyone that joined today. I'm glad to be here. And so how did I get here today? How did I, come to have the knowledge base to be here? And I was introduced, and to use my late husband's quote, I was introduced to the endocannabinoid system by him, and it was honestly like seeing the sunset for the first time. Things just made sense. Our master regulator, our endocannabinoid system, is involved in every single system in our body. And so now if you come at cannabis from the lens of the endocannabinoid system, things make sense. So once I learned about the ECS, that's when I dove down in the cannabis rabbit hole, so to speak, to learn to educate myself on something I did not learn about in nursing school, in nurse practitioner school, even as a biochemistry major learning cell biology, I did not learn about the ECS. Next slide, please. So I have my bachelor's in science biochemistry, as I mentioned, and I've been a nurse practitioner for 13 years now, working in multiple roles across Mass General Brigham, both inpatient and outpatient, multiple leadership positions, education, and working on quality improvement initiatives. And I was the first cannabinoid care nurse practitioner within the MGB, starting here in 2021. And within ECS Wellness, I have helped to develop standards of care, including co-authoring the ECS Wellness Provider Manual, which has been used to cross-train cannabis nurse practitioners working in a standard card-focused, certification-focused practice to transitioning over to a more academic integrative medicine model focusing on the endocannabinoid system and cannabinoid care, offering actual cannabis recommendations and solutions, and we are within the Mass General Brigham system. Next slide, please. And so just to reiterate a point that Drew has already started and to make, and hopefully this will really start getting your gears turning as you go back to your jobs. Cannabis stigma is a patient safety issue. It has been a patient safety issue. And it's time for us to really shift our own feelings and our own self judgments or our own opinions on cannabis. And really, again, Schedule 3 is the call to action. Next slide, please. So as I've surveyed colleagues throughout the years, and actually these are quotes from very recently, there is a big theme across even an academics healthcare setting where there's this don't ask, don't tell kind of attitude or check the box attitude, such as I asked if they use cannabis during the social history, and if they do, I just don't go further. That's just like, yep, they use cannabis. I don't have time to go further. Or another primary care colleague that says, I recommend cannabis gummies for sleep. I think they work great, but I direct them to the bud tenders because they know the products best. Or, you know, I recommend a CBD THC one-to-one product generally for my oncology patients, but I tell them to go ask the bud tender because they know the best option. And then another primary care colleague, they have access to cannabis in Massachusetts. If they're over 21, why would they even need a medical card? And then a psychiatry colleague, I don't think any of our patients should be using cannabis. So clearly there is all kinds of opinions and, you know, whether or not they're based and rooted in evidence-based opinions, that doesn't matter. It's just, it clearly shows that there is not a standard way of how we approach these patients in both primary care and specialty settings. Next slide, please. So this lack of clinical standardization, and again, I'm seeing it on the front lines. There's no standard for cannabis screening, whether you're, you know, talking to patients during the social history, check, okay, they use cannabis, that's that. Or you do, you know, document it elsewhere within the medical record, such as our clinic, who we document medical cannabis use in the problem list. But there's no standard approach to cannabinoid reconciliation. Do you use cannabis? There's so many various cannabinoids, and there's so many routes, and there's so many, there's various frequencies. So those are not being captured anywhere. You could be, you know, a patient could be consuming a non-intoxicating product, but if they say, yes, I use cannabis, it's a non-intoxicating product, I use it once a day, whatever, it's not captured, and it's just cornered into this hole with the stigma of, oh, they're a cannabis consumer or they're a cannabis user. Our approaches to patient care are not patient-centered. So even of those that do certify for medical cannabis and practice in this field, a lot of times it's just this, yes, you qualify, here's a blank check to go get whatever you want from the dispensary. That's not a patient-centered approach. That's not a counseling patients on what to utilize to treat their presenting symptoms, really their presenting condition. And what if they're coming for symptom management, but ultimately that underlying condition has not been worked up? They're going to a card-focused practice, and they may actually need further workup, and maybe cannabis isn't the right medication for them, but there is no standard approach to that and how we treat these patients. There's no standard approach to follow-up cadence. Most clinics out there, depending on which state you're in, that determines, some states require you to see your provider twice a year. Some require once a year. In Massachusetts, we have an ability to certify patients that are qualify for more financial hardship and have financial difficulties for up to 2 years. Who's following up on those patients during that time to see if their medication is working effectively, or worse, if they're developing a cannabis use disorder or side effects from over consuming cannabis? There is no standard follow-up cadence. And again, the same thing, just to reiterate, the patient-centered approaches, cannabinoid reconciliations don't happen. Visits are not follow-up visits are not based on medical necessity. If you're coming to any provider for anxiety, for example, it's not like, okay, great, here, go to the pharmacist and ask, and I'll see you next year. That is not a way we manage patients, and that is not how we should be doing this with this medicine either. Next slide, please. Again, certification has outpaced care coordination. So a lot of systems do not interact with standard health records, and cannabis practices are advertising the speed that you can do it online, get qualified today, or you can save this much money if you get your card. And it's not, again, when we talk about, and Sherri mentioned, the therapeutic use of cannabis, that is cannabis medicine. And we need to support this as a system in general, a healthcare system and healthcare clinicians, to really work through that and help for the patient's safety. I mean, what happens when the card is the focus of the visit, when clinicians don't have access to someone's actual medical records? Next slide, please. And I think the best way to really nail or hammer in that a point is patient stories that I've seen in clinic. And these were 2 recent patients, and I have a couple more actually from clinic today. But the first patient was 24 years old, and she presented for a cannabis certification to our clinic, ECS Wellness. And she had reported having her medical card for 4 years now. She wasn't on any medications. She has a 3-year-old daughter, and she was actually driving at the visit. So when the provider jumped onto the Zoom video, so the provider clearly asked her to pull over. You can't do a medical visit while you're driving. And the patient was clearly distracted by her daughter in the back seat, but gave the provider a hard time. And then as the provider was reviewing the records from Epic, where in Mass General, we have our Mass General Epic Care Everywhere, but we can see into Leahy and other, healthcare systems throughout the state, and we can read notes. And she noticed that the patient had a history of paranoid schizophrenia. Now, this is a patient that has been hospitalized twice, the most recently 3 years ago, but she's had her medical card for 4 years. And we know as healthcare providers, or for those of you that don't, that paranoid schizophrenia and that diagnosis without a psychiatrist, just in general, we don't certify for that. And without a psychiatrist on board, we're even more concerned. And this patient has been certified for medical cannabis ongoing. And that just speaks to the fact that, I wouldn't necessarily say that the provider who has been certifying her is doing the wrong thing. They just don't have access to the information. If the patient doesn't disclose, and maybe the patient, maybe the patient was asked, it should be part of standard questioning. But again, care standards are not there. Records are not completely obtained before visits, and we can only approach with the information. We can only counsel with the information that we have in front of us at the time we're seeing a patient. So the second patient was a 45-year-old male. again, his presenting chief complaint, so to speak, is cannabis certification. And he reports that that cannabis has been immensely helpful in his sobriety from alcohol and narcotics and benzos, although he still does use benzos on occasion. He has a history documented in his chart of paranoia, but he's followed by an addiction clinic, a community clinic in Boston, meets regularly for individualized and group therapy. He has a psychiatric nurse practitioner, PCP, he follows closely with. And the provider that saw this patient, the patient was very disorganized in his thought process. And she had some concerns about the stability of his mental health, and had actually said, I'm not going to certify you today. I want to talk to your psychiatric team and try to coordinate care. And as we were doing this on the phone with the clinic, looking through his purchase history, it showed that he was purchasing large amounts of THC and concentrates, because again, in Massachusetts, a cannabis card just gives you access. And, you know, as I'm on the phone with the provider, kind of talking through the patient and how to best approach this patient's care, I noticed that he got certified elsewhere by, again, a provider for 2 years, by a provider that likely didn't have access to his full records. So how do we, you know, it's not only just, this is a patient safety issue, you know, and educating the provider who I was on the phone with, who doesn't even know what some of these cannabis products are that the patient is consuming. Next slide, please. So what happens, again, if the cannabis card is the focus of the visit, what happens when clinicians don't have full access to records? If one clinician denies the certification of medical cannabis, there's no standard for follow-up, and how do we continue to support patients, but if you just deny them of access, during one visit? What happens when a patient's primary care team or specialists don't have access to even the purchase history, or even know it's in a system that's elsewhere? They don't know what their patients are consuming, and again, we don't have the knowledge base to really support patients and help patients. And what happens when the patient discloses that they take medical cannabis and the patient just leaves it at that? And another example from clinic today, an oncology patient is appropriately and effectively using cannabis on his cancer journey. And he shared that his team is mostly like, don't ask, don't tell, but that's not a great way to approach it. There's drug interactions with chemotherapy and cannabis. So, luckily he has us and we support him with that, but that's not, just because a patient has a cannabis clinician, so to speak, are they really taking the time to really look at the full picture, and who's sitting in front of them? And just because they have their card does not mean that it's without risk or harm. Cannabis is a wonderful medicine, but it does, there are some risks, and we need to be able to support our patients. It's not safe to assume that someone else is just managing their cannabis. Like, yes, they're a medical cannabis patient. Okay, somebody else got it. We need to educate ourselves as clinicians to look for drug interactions and harm reduction strategies. How are you utilizing cannabis, and are you using it effectively and safely? Next slide, please. So again, Schedule 3 is the call to actions for healthcare clinicians to start to approach cannabis as they would any other medical intervention or behavior. Doing a cannabis screening during every medication reconciliation portion of the visit. Do you take cannabis, and do you consume it medically or for recreational purposes, or both? And a lot of times it might be both. You know, a cannabinoid reconciliation and documentation. What cannabinoids are your patient using? What ratios? What products? What route? How often? And where are they in the medical record, so that they can be visible to everyone in the care team. You know, any cannabinoid recommendation should be patient-centered, including endocannabinoid system production modalities. So that's where your lifestyle medicine comes in. That's where your mind-body medicine comes in. That's where your meditation and mindfulness come in. It's essential. It's not meant to replace cannabis is not meant to replace those. It's meant to support and enhance those things. And if you're not comfortable with cannabinoid protocols, the bud tenders mean well, and they do have some knowledge about the products, but they should not be advising what patients are taking and how to treat their medical condition. That's what clinicians are for. That's why we go to nursing school. That's why we go to NP school. So look for a provider in your area if you're not comfortable. And the Cannabis Clinicians, Society of Cannabis Clinicians has a directory, as do other professional organizations. So you can find those in your area that are really focused on cannabinoid care. And again, I call those of you that are in cannabinoid care to schedule follow-ups based on medical necessity. Just because your patient tells you that they're using cannabis safely and effectively, and it is helping their symptoms, it may not be the case. So we have to, just like any other medication, we have to dig in a little bit deeper, take the history, and follow up if you have concerns. Next slide. I think that's it.
That's it. Okay, Joe. Thank you, Megan. That was amazing. And batting cleanup here, it's as you can see, we're used to doing business the way that things are. There's a standard way of doing things, and there's an ideal way of doing things. And as Sherri and Drew and Megan just alluded to, we're in a progression here in adding cannabis as part of the healthcare lexicon. So like many people, my journey to cannabis nursing started as a patient. I crashed my bicycle. I was out on leave having surgery, and I was introduced to CBD through my chiropractor's office over a decade ago. And that was the impetus to me learning how to heal myself. And as I was recovering from those injuries, I started to heal from chronic illness that I had had for up to 20 years. And I was like, my gosh, if I can help myself, I've got to help others. And that's how I fell into this industry. It truly changed my life. And so what began as a personal healing journey for myself, it evolved into a mission to help patients, caregivers, and healthcare professionals better understand cannabinoid therapeutics. And over the past decade, our work has grown from community education into evidence-informed training programs, clinical resources, professional development, and patient support services. We've been creating what we needed as patients when we first started to go to the dispensaries and discover all of these products, like a kid in a candy shop. But you go into a dispensary and you're like, how do I use it for XYZ condition? And they're not going to tell us. That's what we are for, training the next generation of healthcare professionals. So cannabis changed my health, and then education became my purpose. So cannabis nursing is emerging as a specialty. Sherri talked about the Cannabis Nursing Scope and Standards of Practice, which is out, and not a minute too soon, because nurses truly are the game changers. Cannabis use is already occurring across every healthcare setting. It always has been. We've been using this for hundreds of years. And decades for sure in this country, but just again, not disclosing it. Patients are using cannabinoids for chronic pain conditions, sleep disorders, cancer symptom management, and some are treating cancer itself, neurological and neurodegenerative conditions, mental health concerns, and healthy aging, wellness, and prevention. As we age, our endocannabinoid system begins to wane, just like vitamin D and estrogen. And so supplementation is something that we can teach people to help to stop some of the slowdown that is happening with all of us as we age. And nurses are uniquely positioned to provide the education, the assessment, documentation, patient advocacy, and clinical leadership within our healthcare settings across the spectrum, from hospitals and medical groups to managed care organizations and health plans and case management and work comp, all across the board. Cannabis is going to be a part of our future. And the future of cannabinoid care will require strong nursing leadership. And so what do nurses need to learn? First, train yourself, and all healthcare professionals, everybody, but I do believe nurses are the ones that are going to play a pivotal role for patients and the systems. So healthcare professionals need practical competency in the endocannabinoid system, this master regulatory system that regulates everything else. It makes sense that we start there instead of seeing it as an option of last resort. Cannabinoid pharmacology. What are the pharmacodynamics of these compounds, these phytonutrients like CBD, THC, the minor cannabinoids? Where do they go in the body? What are the receptors that are involved? Not just CB1 and CB2, but receptors all over the body. And then what are the routes of administration, and how does that affect product selection? How do we teach clinicians the pharmacokinetics of stacking these and inhalation to sublingual to oral to topical to transdermal to suppositories, and how to mix and match them so that the patients then have true patient-centered care and agency to put together their own toolkit and to be responsibly using these in an integrated fashion. And then dosing principles. What are initial titration, and how do you go from there? What is biphasic dosing with this? And how do we start low, go slow, stay low, and keep tolerance low? And then safety considerations. That leads into cautions as well as fall risk and driving, and then drug interactions. We know that cannabinoids interact with the CYP450 enzyme family. How does that interact with liver metabolism of other pharmaceuticals, and how do we teach people spacing so that medication can be optimized? We want people to be successful with this, and a lot of times they'll say, I tried CBD, it didn't do anything, or I've had horrible side effects. A lot of times we can look at it and see that they might be having side effects of the pharmaceuticals because of potentiation and that. So, and then documentation and reconciliation. How is this showing up in the MAR? And then, in my dreams, I see that healthcare systems are going to interact with the medical cannabis dispensaries and weed maps, where they'll be able to pull it right in to the pharmacy system, and they can then say, okay, I'm taking a 20-to-1 or a 1-to-1, X number of milligrams or a dropper full, and we'll have relativity on what that truly means. Because 10 milligrams is not just 10 milligrams. It goes across the spectrum, and we want people to know how to do this. And it really is about patient-centered counseling and teaching. We've been talking about patient-centered care for 40 years, as long as I've been in healthcare, and now this can be something that is going to bridge that into reality. So education reduces fear, knowledge reduces stigma, and competency improves care. So the future of cannabinoid healthcare: how do healthcare systems operationalize cannabinoid therapeutics within the existing clinical, regulatory, and reimbursement frameworks? As healthcare evolves, clinicians must be prepared to integrate cannabinoid conversations into routine care. It should not just be somebody that comes into the ER and says, I took too much of an edible, and they get cannabis use disorder slapped on their chart. And then support patients using botanical and pharmaceutical cannabinoid therapeutics. So botanical is going to stay in the dispensaries, but now we have Schedule 3 botanical versions, but also the pharmaceutical Schedule 3s that are coming with drug innovations, where we're going to have compound pharmaceuticals with various cannabinoids, terpenes, maybe botanicals, that is going to be like Sativax on steroids that I have a dream with. Improved documentation and care coordination between the treatment team members and specialties, influencing policy and organizational readiness. As schedule changes are starting to be implemented, there is a lot to do. And then we're going to lead the next generation of cannabinoid healthcare. Schedule 3 does not create the need. It reveals how urgently the need already exists. And like we said, patients are using this. So if you want to help assist the 50 million Americans that are using cannabis, or 30%, as Drew said, of Americans using cannabis in this country, you need to get ready to lead. So the future of cannabinoid healthcare requires training. And so we've put together training programs that encompass everything that you could possibly need to learn, starting with the history and the evolution of legal cannabis, not even just here in America, but globally. The endocannabinoid system science and the discovery and the research into CBD and THC that fast-tracked this study with going back to Israel and how it was created to really understand cannabinoids, because they just saw them as a drug of abuse. But now that was the cradle of understanding that this is the master regulatory system that is going to help us heal everything else. And then the clinical and practical applications. What kind of conditions does this work for? What is the research to substantiate that? And what are some of the starting protocols? Safety considerations and cautions in the fine print, documentation and scope of standards and scope of practice, patient education and teaching templates all done for you, professional and business and clinical development, especially in our mastermind sessions that are monthly, so that we are able to support you going forward. So the CNHC, the Cannabis Nurse Health Coach Program, is to me the most comprehensive cannabis curriculum available today. It's designed for nurses, and there are CEUs for nurses, but it's for all licensed healthcare professionals: physicians, pharmacists, mental health providers, naturopaths, acupuncturists, chiropractors, students, and all healthcare professionals who want to master cannabinoid medicine. So that is it on my side.
All right. And so this has been amazing. Let's give a round of applause for all of the amazing speakers, nurse entrepreneurs, expert cannabis nurses. And now we are going to have a call to action. We're just going to go through one by one. We're all going to say our call to action, and then we'll do some Q&A. Okay. So my call to action is to explore education, coaching, and consulting, at Holistic Caring in the Green North, or any other platform. You need to start learning. For people that are new, that haven't used cannabis as a medicine, or people that want to try products or haven't done products, I'm offering a free emailed care plan. We offer them Bloom Hemp CBD. We also have a free network. Holistic Caring Network is complimentary and free, and we host some free educational programs, our paid educational programs, all of our webinars and support groups. We have a plant medicine support group that meets monthly. And so we just encourage you to join and to learn and to keep learning and growing, just like the cannabis plant. And then Drew?
My call to action is simple. If tonight's conversation challenged your thinking, start asking more questions and I wrote a book, Healthcare Cannot Manage What It Cannot See, because all of us love to go down the cannabis rabbit hole in our specialties. And it really breaks down where the operational gaps are in our entire healthcare ecosystem. It prints in August. Please order a copy. Clinical leaders should have this as a tabletop reference. You're going to need it as you're building with the tools that are available through Holistic Caring and the Green Nurse. You're going to want to know where to put those tools and how to implement them into the workflows and what language needs to go into policies. And join me. I'm doing a listening tour with our nonprofit. We are having daily interviews with healthcare leaders, clinicians. If you know anybody who would love to share, how are we identifying cannabis is some of the questions that we're asking. How are we documenting? How are we learning from it? And connect with me on LinkedIn. I'd love to stay connected. I think the more that we have these conversations, the more that we really call it out that we need to have better visibility into what the holistic patient experience is, the more we're going to catch on, and it's going to catch traction, and we're going to be able to really impact people's lives. Thank you for spending your evening with us. I appreciate you. Megan?
Thank you, Drew. So yes, if you are a healthcare clinician, if you are a nurse practitioner, a physician, a PA, an MA, anybody that does a medication reconciliation, consider asking your patients if they take cannabis and how they take it, do a cannabinoid reconciliation, and if you are, again, in Massachusetts looking for help, we do see patients. We have an insurance-based model, and cannabis is just one of the things we do. Again, we're called ECS Wellness because of the endocannabinoid system, and we focus on helping patients to balance out from the ECS standpoint using cannabis and other modalities. If you're looking also for information, please feel free to join our educational newsletter, check out our website to see educational blogs, connect with me via LinkedIn, reach out with clinical questions or patient stories. I love to hear. And you can also email us at office@ecswellness.com. But, you know, I'm here to support you, and thank you all for spending your Thursday evening with us. So, Elisabeth.
Okay, and so I would ask that you join the Cannabis Nurse Health Coach Certificate Program. This has been my life work. It has got 30 continuing education units, which is all you need for your 2-year renewal here in California. It is 53 units and chock full with everything you could need to learn. We also offer the 1-year mastermind where we dial it in and meet every single month to talk about clinical and business development and give you a toolkit of all of the forms and teaching and e-resources that you will need to either start your own coaching practice, if you're retiring from conventional care and you want to hang out your shingle and be a holistic health coach, this is something you want to add. And then, of course, being the most valuable player on your unit or your health plan, etc. So this has got something for everybody. And of course, you can reach out to me through my email and, of course, LinkedIn as well. I'd love you to connect.
Okay, and then just to wrap up, we do have a closing poll question. After learning from our expert panel of cannabis nurse entrepreneurs, do you feel more curious and called to learn more about cannabis for health, healing, and wellness? Let me just put that poll up. Here we go. Yes, no, still thinking about it. So do you feel more curious and called to learn about cannabis for health, healing, and wellness? All right, there we go. We did good. Published results.
Everybody's
Okay.
than they were.
Yes. And then next slide. And then you were going to get a copy of the slide deck, and this is a summary of resources. These are all live links where you can reach out to us, each of us individually and as a group. And then also the next one is books and blogs. So these are some books that have been written by cannabis nurses. All of these books have been written by cannabis nurses, which is really, really amazing. And then these are all of our different blogs that are available for free education so you can learn and become empowered. And now we are going to go to Q&A. So if anyone has a question, I'm going to pull up the Q&A chat box here, and I'm going to read the question out loud, and then all of us will answer it. If anyone else has questions, you can put it in the chat, or if someone wants to come online, you can raise your hand. So the first question, and the only question that we have, is we are all aware a tolerance forms with long-term cannabis use. How should that be handled without infringing on patient choice? Before we decide this was a medication, this was a plant that freely grew. My concern as the process evolves, it will become a control issue, thus turning it back to a closed door use. Thoughts? So I'm just gonna start by answering that personally myself. So, you know, again, like I've been doing this for a long time. I found cannabis as a medicine back in 2012 when I was sick and suffering and on over 18 pharmaceuticals, and I figured out how to make cannabis work for me in an appropriate way. And I truly feel that I'm using it therapeutically. But again, what we see issues is with too much THC use. So it's about balancing. It's not about over consuming and using one method all the time. It's about fine tuning the endocannabinoid system in a way. So again, I'm talking about medical use, not adult use or recreational use, which is very, very different. So when patients are using this to manage symptoms, whether it be chronic pain, anxiety, sleep, neurodegenerative disorders, the list goes on, you need to have it, you need to pair it, not just with health and wellness activities, integrative functional health tools. And so And our concern as nurses, and I'm going to just say this, is I've been taking care of a lot of pediatric patients recently, a lot of teens that have been over consuming high amounts of THC using the concentrates and the vapes, and they're becoming extremely dysregulated. So this is not about us trying to control, but it's about safety and about managing health outcomes and about helping people to use it therapeutically and safely. And so what we've seen over time, Elisabeth and I have taken care of over 6,000 patients in the past 10 years. We generally don't see patients that want to use it recklessly. We see patients that want to use it appropriately to get better and to feel good. Some of the patients that are coming to us now have gotten into trouble because of the overuse of THC. They're going to dispensaries, they're asking for help, and they're being sold high doses of THC, concentrates, flowers, edibles, etc. And there's a lack of the other cannabinoids that are there to balance it out. And this is what we're seeing, how patients get into trouble.
And there's also a lack of clinical guidance and judgment, because, when patients are using cannabinoids medicinally and therapeutically, they don't really get into tolerance that much, right? If you look at the Sativex trials, where somebody is using a 1-to-1 CBD THC oil for years, they're not losing efficacy, they're not growing tolerance, they're not having side effects, and it's because they're taking a methodical titration approach. And so when you stack products, also, you can use the lowest amount of each one so that you're not getting tolerance. And then the other thing is, with inhalation and THC, it is good to take tolerance breaks every few weeks, take a couple of days off, 3-4 days helps reset the ECS. And of course, you can tone the endocannabinoid system with many other ways, right? Nutrition, whole foods diets, exercise is the number one, good cardiovascular exercise, connection, social connectivity, and getting proper sleep. All of these whole foods and whole living is a good way to maintain that. And then you won't get as much of a tolerance issue.
And I'm just going to close up, and then I'll let our other panelists speak on this. So I've replaced 18 pharmaceuticals off of all pharmaceuticals except for one, because I have to take it because I got a blood clot, and I have to take Eliquis. But the bottom line is I don't have a high tolerance because I take tolerance breaks, I don't smoke all the time, and I use balanced ratios. And I also tone my endocannabinoid system using other things besides just the plant. And I will let Meghan go next.
Yeah, of course. I think that from clinical practice, and we have seen our model of care has fortunately allowed us to see thousands of patients. Our practice sees over 3,000 patients annually. And we follow patients longitudinally. So I've have patients that I met in 2021, and I see them every month, every 2 months, whatever cadence based on medical necessity. And I have had patients on the same products, the same cannabinoid ratios for a long time. Also remember that tolerance is not just, it's largely THC. You can have, but that doesn't mean you have to, if you're using one product one THC product, and you're building up a tolerance to that product, sometimes rotating, or again, taking a break from the THC. It's not all about THC. And as I educate colleagues and patients, that's largely what we focus on. A lot of patients do get into trouble. And then when they come to see us, as we do our motivational interviewing and non-judgmental cannabinoid reconciliation, it's, everyone just wants to feel better, and they find something that makes them feel better. And then sometimes they can get into trouble, but invariably just talking to them about the plant, it completely decompresses them, and they feel like, oh my gosh, nobody's ever asked me if I utilize CBD or some of these other cannabinoids. Please help me. I would love to. So just to reiterate what Sherri and Elisabeth are saying, I'm seeing that real time in practice every day. And it's about the ECS, it's about the endocannabinoid system. It's not about just one, cannabinoid.
Okay. Drew.
Hey, so I'm going to flip it a little bit. I always do, right? I think that that's an important concern. It's really one of the reasons I focused on visibility rather than control, because yeah, you can develop tolerance and there's ways to clinically coordinate that, as the speakers before me shared. But from a clinical leadership perspective, healthcare providers should be able to understand, they should be able to assess and discuss cannabis as part of ongoing care. Like, I don't believe the answer is creating more barriers to disclosure, because of course history shows us that if we create barriers to disclosure and we lose trust, people just stop talking to healthcare providers. And when they're not talking to us, we're losing visibility. So my concern becomes, do we have enough information to support safe, informed decision making? And we can't lose the autonomy that patients have to have self-directed care, but we need to make sure that is clinician guided as well. Because every endocannabinoid system is different and everybody is different. So really the goal is not control. The goal is not directive of clinicians over your cannabis consumption journey. The goal is truly transparency, like creating an environment where patients can honestly disclose what they're doing without the fear, and where clinicians have the evidence-informed conversations, the bias-free conversations, and real conversations about benefits, risks, tolerance, interactions, effectiveness, all the alternatives, because what they want us to focus on is control, and that control mindset. People are going to go underground if we really start moving in that direction. Even though cannabis is a commodity, it is a medicine. And the place where I push back is when we're saying we're talking about medical cannabis. Cannabis is cannabis. Cannabis, if you're taking the medicine, you're taking it for a therapeutic reason. You may not know you're taking medicine for a therapeutic reason. You may just think you're taking it to feel good. And again, the underlying condition is maybe some anxiety. The underlying condition is maybe unresolved trauma. Maybe there's tension in your body. And you're just like, oh, I'm just relaxing. But it's medicine. So we really have to start talking about it as medicine, start documenting and looking at it in our systems as medicine, and take all of our emotions out of the story when we're really interacting with this, because the patient experience is very dependent on being able to have that interaction with their clinician. And if that patient experience is going to be tied to that patient outcome, our responsibility is not to have an opinion about what they're doing. It is to guide them to do it safely, and to ensure that, especially as leaders, that you're protecting your facility and you're able to have documentation defensibility with these tools and these intakes. And you're able to say, yes, I educated my patient. And if your patient comes back into the ER with an adverse drug reaction because you did not educate, that's a utilization issue too. So it's not about just really giving the control to healthcare, but giving healthcare the tools to be able to manage and help people self-direct their care. I started this journey with cannabis as a patient as well. And my goal was to define my own wellness journey. That's always been my goal. And that's what I want for everyone, to be able to define their own wellness journey. And as a leader, I have to be mindful that that wellness journey, especially some clinical environments like long-term care and assisted living, includes cannabis, includes CBD. And we need to have those conversations for how we support patients in those environments, to make sure that we know if they're starting a new medication and there's a co-exposure risk, that we're able to assess that. We're not going to be able to tell the patient, you got to stop one medication. I can't tell a diabetic to stop taking his insulin because I don't like it. You really are going to need to say, this is what these medications are doing. How do you want to be part of this care planning process? To define what's important to you, what symptom management looks like, and working with clinicians that are educated, informed, and have the expertise to be able to guide that conversation. And I'm going to add another call to action at the end of this question. Really become an educated expert clinician. We need you out there. We need frontline clinicians to say, hey, and I'll tell you a quick story. We had a patient that started warfarin and was taking edibles and did not disclose. And it took 5 transfers to the emergency room before a clinician in the emergency room said, hey, did we check a tox screen? There's some drug interactions that could be happening here, because we don't have enough people that know. So it's really important that you become one of those people that know and become part of the army of people who are pushing patient safety. And you are then becoming a really valuable part of the workforce, and create opportunities for yourself to educate your peers and grow in your leadership in nursing. Because I think from my perspective, that's the most important part, really removing the control aspect and bringing this back to the fact that it's medicine.
Completely agree.
Here, here.
Yeah. I mean, and I can understand the, Jennifer's concern about the control, because here's the thing. Once you're a patient and you figure out how to make it work for you and you're using it therapeutically, you're not going to want some clinician to come in and to tell you to stop doing what you're doing, specifically if you are balanced and you are functioning and living your best life, right? Like, and I could give a story to myself. For example, moving from Massachusetts to California, setting up with a new primary care doctor, she was doing a medical medicine reconciliation on me, going through all my list of medicines. No, I don't take that anymore. 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 And she's like, what do you take? And I said, I use hemp-derived CBD from Bloom Hemp CBD, and I use a little bit of THC at bedtime. Do you know what you put on my chart? Synthetic cannabis use abuse. Synthetic. And so once I saw that, I had to go back and make an appointment and have a heart-to-heart conversation with her and say, no, there's not one thing synthetic that I am taking. I am not abusing it. Just because I'm not taking the pharmaceuticals doesn't mean that I am not taking care of myself. I've chosen to use holistic caring modalities to manage my symptoms that I have from these various conditions. And I've been doing it very successfully. So anyways, so I can understand that control issue. We don't want, people to come into control, but we do want people to be safe, right? And that's it. We don't want adverse events. We don't want people to start taking things and to have adverse drug reactions. And again, I read an article recently too about a cancer patient who had to go on some steroids, and he was using CBD edibles, and he got into trouble with his liver enzymes. So again, it's really about education, empowerment, discussion, disclosure, and having thoughtful conversations to improve quality of care, which is going to improve quality of life for our patients.
I wanted to add one thing to that, just because I was moved to, and I think that another part of the conversation that we always need to bring to the forefront is, what is the patient experience and who is most harmed when we are not disclosing cannabis? Who is most at risk? And it's the most marginalized people that our veterans are at risk. They can't talk about it because of their medical benefits. They cannot have a moment for that. And I always think we can't talk about cannabis without talking about health equity, because if we are not measuring how cannabis is impacting health outcomes, we are completely ignoring a data point in a cohort of patients that could be at risk or could be benefiting from the plant way that we're not documenting or capturing. I think a lot of the focus that we sometimes have is on the negative cannabis story of lack of documentation, because we only have ICD codes to support negative connotated and undertoned documentation. We've been clumped in with use disorder because the research only was done for harm reduction. And we don't have a way to truly document for reimbursement therapeutic cannabis use. So I think that that's another thing that nurses need to start asking for. What is the language that we need to be using in our medical records? What is the language that is not available to us to actually document this without bias? Because that is part of the problem. If we can only document cannabis use disorder so that we can get reimbursed, and we can only document cannabis hyperemesis syndrome and talk about that, those are the only things we're tracking. And that's why negative stories keep perpetrating the media and creating narratives that are unreal and unnecessary, and putting patient access at risk in states because people are afraid instead of educated. So I really think that that's going to be extremely important, that nurses really take this on. And one of the things, I told a story about Jamaica yesterday, and I said I was in Jamaica once driving in a car, and the taxi driver was going at a very high speed. And I said, hey, isn't the speed limit such and such? And he said to me, oh, that's just a suggestion. Schedule 3 will become just a suggestion if there's no mandate behind it. And that's why when we have nursing voices, when we have organizations that are talking about policy at the federal level, and we're talking about education needs for our nurses, we need to be talking to our leadership and our credentialing organizations and saying, what is your role in ensuring that our workforce is prepared for this? Why are we not asking for policy that mandates? We are all mandated for license renewal to take CEU courses. Why isn't one of those CEU courses a cannabis CEU course? 30% of your patient cohort is consuming. What is the responsibility of legislation and policy and government in ensuring that it's not just a suggestion? And I think that that's the other conversation that as we're having education conversations, and I typically am the odd duck out in the room because in clinical leadership, we don't talk about Bruno. I loved Encanto and we're like, oh, cannabis, that's not our issue. We don't have any data on it. And that is the problem. So we need to continue to capture the data. We need to continue to share the data. We need to continue to aggregate the data and then also say, hey, we need policies to support the workforce that is most at risk for liability, indefensibility of their documentation. Nurses that carry insurance, they carry it for a reason. And we are at risk because we're at the point of care. We are the voice of the education. We are the care planners. We are the care coordinators. So we need to demand that policies support the education that we need to do our job safely and well.
Good. Yep. Now, Elisabeth did put a question in for some of our attendees.
Well, somebody asked, for those of you who are affiliated with Healthcare Questions, do you do training for nursing staff on the ECS and cannabis therapeutics with support of the leadership team, at least palliative and pain nurses? And so we do. I would love to have more systems reach out to us to onboard training, because that's what we do. In fact, I just finished today a new program called Practical Applications for Healthcare. And this is going to be just a 4-hour program. So something that you can get in and get out and learn from everything that you could possibly need to learn, not in as much depth as CNHC, but in an overview form. And it would be perfect for healthcare. Everything that we talked about here today is in this new program, Practical Applications. So definitely go to the professional programs that I put in the chat and check out some of what we do. CEUs are available for nurses nationwide because California Board of Registered Nursing has reciprocity, so we can train nurses across the country. And it's as I mentioned in my add-on here, pain and palliative care patients need this the most. All they're getting is opioids and NSAIDs and gabapentin and all of these things, and we can do better. We can add cannabinoids that make all of those other things work better at lower doses. And we can then keep them safe so that they are supported, as opposed to fumbling around in the dark with a bud tender. So.
But I just want to add too that I've been fortunate enough to, within my network, be invited to do grand rounds. And one of the educational resources that will be listed in the slide deck is a 3-hour CME for nurse practitioners looking to become certifying nurse practitioners in Massachusetts that qualify. So if you are out there in Massachusetts, but just in general, that does have more of a provider focus that can kind of enhance what Elisabeth and Sherri are offering. But if you have that knowledge, it's essential to share it with our colleagues. And that's what we're trying to do. And I have to say the majority of the colleagues that I'm interacting with are welcoming that information, and it's changed their practice. I was surveying a GI nurse practitioner from the neurogastro, so the motility clinic, these complicated patients with disorders of the mind-gut connection. And I asked her, she refers a lot of patients, like, how do you even get to the point where you refer patients our way? It's just part of her standard reconciliation. But what kind of was just like, oh my gosh, is it working? Like she asked, is it working? And the reason why she has the confidence to do that is because she's seen it. She's asked her patients, she's learned about it. She's asked me, we've discussed cases. So it's really essential. The education is going to be the key.
All right. So do we have any other questions from the audience? Anyone that want to come off and ask a question or in the chat? If not, we're going to wrap it up.
Can I add one more thing? I was going to say.
Absolutely.
I like to, Megan just kind of inspired me for this one, but asking the questions and having the positive curiosity. I know that as a nurse leader, there's some conversations that when the staff bring it to me, I'm like, that's not on my metric sheet. Okay. That's not what I'm being measured against this month. So go along. And I think one of the ways that you can bring this information to your leadership without being a cannabis advocate is to ask curiosity questions and say, hey, you know, an organization like Americans for Safe Access just put out a whole bulletin about what your rights are and what to ask the hospital and what to put in your HCAP survey if they don't treat you well. And we don't have a plan. Like, what is our plan when the medical patient comes in? Just ask, hey, what is our plan? I was thinking about what's happening in the news, Schedule 3 coming up. What is our plan? It's now like, just ask, because that's going to make that leader go, oh, snap, I don't have a plan, right? And then they're going to have to go find the answer to get a plan. And hopefully they can connect with Mack Consulting or people in the space that are able to connect the dots and build the infrastructure and help them kind of guide through the project planning and deployment of a successful integration into operations. And that would include, because my plan always includes education, and I am not the educator. So it's really important. And this is why we collaborate in this way, because I'm not the certifying clinician and I'm not the educator, but I can build that system, and I'm going to need these teams and these resources to come in and support. So it's really important to ask, what is the plan, so that that leader is triggered to start looking for the answer and actually have a plan, because the last thing a nursing leader wants to do is get caught without a plan.
And basically, we're going to be serving our patients and serving our nurses and truly helping to change the paradigm of healthcare with Schedule 3, if we're all doing the right thing, asking the right questions and learning. So this has been an amazing presentation. The Green Nurse Podcast, Clinical Conversations is this episode. Thank you for joining us all today. And again, those that registered and has shown up, within the next hour, you will be getting an email with a copy of the slide deck that we presented today with all of the information and live links for you to click on. And you will also be able to rewatch this. Those that have registered and didn't show up, they will get their email tomorrow. They will also get a copy of the slide deck and also get the recorded version of this presentation as well for them to rewatch and to share. And then we'll have this on our YouTube channel in the next couple of days. So again, thank you all for joining us. And remember, truly what it's all about living your best life and helping others do the same. Thank you so much for joining us today.
Thank you, everyone. God bless. Happy
Thank you.
summer.